So lots of great data that you guys are throwing out here at the audience, but I want to also keep things practical. So Rivaroxaban, FDA approved indications here for this extended duration in the medically ill. But let's talk a little bit now about specifics. So let's start with Rivaroxaban. What sort of dosing are we talking about?
A loading dose of 160 milligrams, and then after that, a maintenance dose of 80 milligrams a day for that extended duration period of 35 to 42 days.
Okay, that's really practical, really helpful. And what about Rivaroxaban? What do we want to do with that one?
The approved dose is 10 milligrams once a day.
Okay, so really clear what the doses are. Any sorts of worries about renal dysfunction or anything else where they have to adjust, or just start and go with, let's start with Rivaroxaban.
Yeah, I think you have to be careful still, even though the drug, is not cleared by the kidney or very little clearance, you still have to be very careful in the patient with renal insufficiency. So there in the label are guidances to avoid the drug in those situations.
And what about Rivaroxaban?
Well, in the Mariner trial randomized patients to 2 doses of Rivaroxaban based on renal function. So this was at the time of randomization. If they had creatinine clearances under between 30 and 50 milliliters a minute, they had a reduced dose of Rivaroxaban, a 25% reduced dose or a 7.5 milligram dose. And that was shown to be completely ineffective in the Mariner trial. So I think the 10 milligram dose, when we do further analysis looking at both the Magellan and Mariner database, what's more important than renal dosing, which turned out to be an ineffective strategy, is actually keep those key bleed risk criteria in mind when dosing the renally insufficient population. So 10 milligram continues to be the optimal dose even in the renally insufficient population.
Yeah, really great points. It also points to something I think that's really important for the audience. I mean, there are a lot of NOACs out there. We're talking about some here. There are lots of indications, AFib, DVT, PE. We talked about CAD and PAD, which is specific to Rivaroxaban, 2.5 BID. So it can be pretty confusing, then throw in renal dysfunction, potential adjustments in doses. So there's a lot of doses. I actually wouldn't recommend that anybody just try to keep it in their head. I know I have a hard time keeping it all in my head, and I think it's important, to check. And it's quite useful to have a pharmacist on the team and consult, and hopefully an electronic health record, that provides a backstop just to make sure you're not accidentally prescribing the AFib dose for somebody that's got PAD, for example.
That's where order templates make things really easy, because if it's a VTE prophylaxis order template, you'll have the right dose.
Yeah, I think it's so important because it's very hard to keep it. Even for people that, like us, that are immersed in this field, I get confused. There's just so many trials and so many doses, and sometimes the approved dose isn't exactly what was studied in the trials, and it just gets really messy, I think.
And Deepak, to your point, it's an important point that the 2.5 milligram dose of Apixaban twice daily was completely ineffective. So what I warn people is not to make that extension to say, well, Rivaroxaban worked in the low dose environment, but so therefore Apixaban will work. Actually, the ADOPT trial was a trial specific to medically ill, using almost an identical trial design to Magellan. Again, randomization at hospital admission, 2 co-primary efficacy endpoints at day 10 and day about 35 or so, both driven by mostly asymptomatic lower extremity DVT using screening ultrasonography. But in the ADOPT trial, number 1, they identified a fairly low VT risk population, but the 2.5 milligram dose of Apixaban not only was not effective, but also induced an almost 2 to 3-fold increased risk of major bleeding. So it was strike.
And it's not interchangeable.
Not interchangeable.
You can't assume that dose is going to be effective.
Why is it that Apixaban didn't perform better in ADOPT? I mean, why not?
I think some of it was the population. At that point in time, we hadn't quite grasped onto the concept of really identifying the highest risk populations. So the population enrolled in ADOPT was probably not as high risk for VT and probably still robust in bleeding risk. And I think the other thing, there were some methodological issues with picking up the asymptomatic VTE. A large number of patients didn't complete their ultrasounds, and so I think that probably explains why we lost signal there.
Sure. So perhaps if there were an ADOPT 2, maybe in the right population it could look better?
Right. Clearly, what the trials have been doing, and you know, Alex and Mariner and Mike and Apex made a substantial advancement in the way we think about medically ill in finally honing down to a higher risk population. No one ever thought that extended thromboprophylaxis was right for every medical patient being discharged, but there's a subset where it is important.
What about Rivaroxaban and dabigatran? Any role at all in this discussion for either of those agents?
Yeah, neither have really been studied in this space. They've been studied in prophylaxis in orthopedic surgery, but not for the medically ill.
Sure, and I think dabigatran is going to be going generic first of all of those, so that's why I asked, just in case somebody thought, well, can we slip that in? So really wouldn't be an evidence-based strategy
No,
or anything
it'd be
anyone here would
off-label
endorse,
and-
correct?
Also
Okay,
important to know, I mean, dabigatran is cleared predominantly renally, and it's an issue with these medical patients. So
Sure, a lot of them have
yeah.
renal dysfunction and fluctuating renal function as well.